Welcome to Erin's webinar entitled Radiology Team Safety to Err is Human. Presented this evening is Dr. David Jordan and Greg Lockhoff. Dr. Jordan's background, he is a senior medical physicist at University Hospital. He's University Hospital Case Medical Center and also the Clinical Associate Professor of Radiology at Case Western Reserve University in Cleveland. He completed his PhD in nuclear engineering at the University of Michigan. He has been a medical physicist since 2004 and has trained dozens of clinical medical physicists. He is an expert in quality control and optimization of medical imaging equipment, including nuclear medicine, and has a special interest in MRI. He is an active member of several of his professional scientific committees in his own profession, specifically of the American Associate of Physicists in Medicine. Greg Lockhoff, he also has a pretty extensive, he is currently the clinical coordinator of radiology at University Hospital Case Medical Center, works with Dr. Jordan. Greg also serves as the president for ARIN, the Association for Radiologic and Imaging Nursing, and he is the chapter president for his local Ohio group. I wonder if there's favoritism there, Mr. Lockhoff. He has lectured extensively on the subject of radiation safety, both professionally to nurses and physicians. He's also radiology nurse certified. That's great. So participants, again, you all will be able to receive the day after the webinar a link to complete the evaluation. Once it's completed, it sort of prompts you to move forward to the certificate, which you'll be able to obtain right away. We sort of do some cross-checks, so the email will be sent once that's done, so sometime tomorrow. Technically, the announcement for this live presentation, you need to have a flash player. This live presentation does not support any iPad or iPhone at this time. This webinar will be available for on-demand viewing since we are recording it this evening. So those of you will be able to view this at any time through a private YouTube channel that we'll be able to send you, and that is the component that will support iPad and iPhone on that YouTube channel. Handouts, I believe that Dr. Jordan and Greg Lockhoff do have handouts available that will be sent to you via email in the future, probably within the next week or so. Again, please know that there is a chat box that is right on your screen there. Feel free to tap in your questions as the questions become, as they come to you. We may not respond to those questions until the very end, but know that they will be responded, and it's nice to chat it in there so we know what to expect. Both the planning committee and the speakers have no disclosures at this time. And without further ado, Dr. Jordan and Greg, please proceed.
Thank you very much, Karen. Welcome to everybody in our audience. Chernobyl, 1986. Interestingly enough, these pictures were all, the first two you've seen were all in color, and there was so much radiation that it washed it out. Still Chernobyl, 1986. This is what happens when your bed's too close to the MRI. This is what happens when you get a special type of haircut in radiology. This is what happens when contrast goes awry. And this is what happens sometimes on a basis with some of the team members. And this poor individual, he was just changing his gown. He sat on that bench, and he just doesn't know how that got up into there. With all this, radiology is a very dangerous place. And I think you would all agree. When you see danger, what do? Do you close your eyes? Do you close your ears? Or do you not say anything about it? Today we're going to talk about a radiology safety culture. To err is human. Now, as we get started in this, we need to talk a little bit about the objectives. By the end, we want you to be able to identify current standards and practices to promote radiology safety, identify communication techniques to enhance radiology safety, and be able to state the importance of personal accountability in radiology safety. Now, this particular topic is very, very close to the hearts of Dr. Jordan and myself. We've lectured on this a couple of times already, and we really got involved in this several years back through a combination of some root cause analysis within our own department, but also seeing that this was a topic that everybody was talking about. It was a cutting-edge topic and something that was important to everybody in radiology. And it had been already seen in some of the various industries, and we've seen that in those industries they were able to show that working on safety really did work, and it really did cut adverse events. And when you start talking about adverse events and you start talking about radiology, two events come to mind most. The first one's Chernobyl, and the other is the Columbini MRI incident. Now, Chernobyl, and when I was researching this, I found this most interesting. I mean, I remember Chernobyl. I'm of that age where I could remember when it went on, but I really didn't get it at that age. And it wasn't until I was researching this and I seen this whole accident pyramid. Well, you can see that 1 and 2 are just minor incidents, accidents. Chernobyl was all the way at the top of this. It was classified as a level 7 nuclear event. Operator error was initially cited, and the RCA, or the root cause analysis, cited operating instructions and design errors as causing it. The other incident that we talk about is the Columbini MRI incident. The Columbini MRI incident, there was a young boy, Michael Columbini, that was injured in a playground accident. And prior to discharge, he was sent to MRI as a reference point for future monitoring of his cerebral injury. Now, he was sedated prior to the exam and placed in MRI with an oxygen nasal cannula. Now, before the exam began, the anesthesiologist was observing the decline in oxygen saturation. When he investigated, he realized that there was no oxygen flowing out of the tube. The technologist that was working in the room with the anesthesiologist was unfamiliar with the oxygen supply. What had happened is that the wall oxygen was being worked on, and in this particular case, they were using one of those big tanks of oxygen, not the little E-cylinders, but the big ones that are on the gurney things that they roll in. And it had a special nozzle that needed change. So the technologist went back to change the nozzle. The anesthesiologist stayed with the patient, and as the oxygen continued to decline, he called out for help. Well, a passing nurse heard the call for help, and she brought in an E-cylinder, but she got it too near the magnetic field, and it pulled it into the machine, striking the boy on the head. Now, what do you call an organization or an industry that's complex, risky, and very safe? You call it a high reliability organization. And it's really hard to say high reliability organization really fast and a lot of times, so I'm just going to call it an HRO. An HRO are systems operating in hazardous conditions that have fewer than their share of adverse events. Agencies that target high reliability, and you realize and recognize some of these: the U.S. Navy, the Department of Energy, NASA. And you can see by looking at this picture of an aircraft carrier why they would target high reliability. Just look at all the planes on there, the little carriers to pull the planes out, the number of men running around on this deck and women running around on this deck. A very dangerous type of situation. Some of the businesses targeting high reliability: commercial aviation. There's a lot of examples coming out of commercial aviation that Dr. Jordan will talk about later on of why that's a high reliability organization. Some of the banking institutions. I found it very interesting when I'm looking at this list is petroleum and chemical industries. The one thing that I found missing from this was BP oil. Perhaps BP oil should have looked at it before they got into their whole Gulf crisis that went on a couple years ago. This particular slide shows naval aviation Class A flight mishap rates. And the piece I want to show about this is you can see a number of events up on the column on the side and the year that it happened down on the bottom. You see that with angled decks, aviation safety centers, and just all these innovations that they put in, it really started to decrease the number of accidents that the Navy had with flight mishaps. And you can see 776 aircraft destroyed in 1954 with all these innovations and really concentrating on safety, it went down to 24 aircraft in the fiscal year 2003. Now this particular graph shows some of the SCRAMs, or the emergency shutdowns of nuclear reactors, and what happens. And you can see once again with the year and the number of SCRAMs up the side that SCRAMs started to decrease. Operational efficiency started to increase as things got safer. Now, always when you talk about high reliability organizations and you talk about root cause analysis, the Swiss cheese model comes into effect. The Swiss cheese model is just saying that in our normal operations that we have stops built into it so that a harmful event doesn't occur. Well, unfortunately, sometimes that if people ignore a stop or if a stop's bypassed, holes start to line up, and that's how accidents happen. For instance, you may have an accident where somebody got the wrong medication. Well, one of the stops is that you check the right patient. Well, somebody, you know, didn't look at the name band to do the two identifications as Joint Commission recommends on the patient. So now you have not the right patient, and maybe somebody didn't do the barcoding that you're supposed to do on the medication before you give it. So then that wasn't checked, and you know, you go through a couple of these and you see all the holes lined up, and all of a sudden wrong patient got the wrong medication, and now we're doing a whole root cause analysis on it. Reliability sciences are principles used to examine systems and processes to calculate reliability. Adopting HRO principles increases the system reliability. For this in healthcare and for us in radiology, it means it minimizes care defects, it increases care consistency, and it improves our patients' outcomes. Now, what will HR theory provide for you? It provides a common language. If you're talking HOR theory, I can go to overseas, talk to my colleagues overseas in New Zealand, and they understand what I'm talking about. I can talk with colleagues down in Florida, colleagues up in Canada, and we all understand the same thing. It permits a communication of lessons learned, and it really establishes and supports a culture of safety. Some of the attributes of a high reliability organization, it's a focus, and to really look at the attributes of an HRO, you got to look at what it is not. You got to look at the non-HROs. Non-HROs, they focus on success. They possess an underdeveloped cognitive infrastructure. They focus on efficiency. They provide inefficient learning, episodic learning. They lack diversity. They're focused on conformity. They filter information communication to the grassroots. They reject or excuse warning signs of quality degradation. In other words, their head's in the sand, there's a problem brewing, and they just don't want to recognize it. Attributes of a non-HRO, and do you recognize any of these? You know, have you ever been in those organizations where you attend meetings and solve nothing? You catch airplanes and you miss connections. You shuffle papers and people tend to lose a few. That sounds like when I have to deal with my cable company. They never figure out why my cable's not working. They meet deadlines on projects on which plugs have been pulled or should have been pulled. And I'm sure that we've all seen a few of those. Now, attributes of a high reliability organization is a preoccupation with failure, reluctance to simplify interpretations, sensitivity to operations, commitment to resilience, and they defer to expertise. And we'll talk about a few of these things. High reliability organizations observe and track failures. In a high reliability organization, a small failure is as important as a large failure, and they try to avoid complacency. Success rears confidence in a single method of doing things and can tend to generate complacency. For instance, and how many times have you heard this? Well, my patients never had a potassium overdose, so why should I change my practice? I think I've heard a variation in my own practice that, well, why should I have to wear a hat? My patients never developed an infection. You know, success narrows perceptions, and it just starts to set you up for a fall. HROs have a reluctance to simplify interpretations. Big organizations, you can only keep your eye on so many issues at a time. And all organizations have to ignore some issues because there's just too many to keep an eye on. By ignoring some issues, it may force them to ignore key sources of problems. So HRO restrains the temptation to simplify everything. They encourage diverse viewpoints to present a picture of possible consequences and responses to early warning signs through a check and balance system. A reluctance to simplify interpretations. They pay a closer attention to contextual leads to differentiation of views and mindsets, and they look for the root cause. For instance, in a drug overdose, the obvious cause may be the resident who wrote a 10-fold overdose, but the root cause may have been that that resident was up all night in an ED with a seizing kid, called a verbal order in to a nurse who was equally tired, and you can see where this goes. HROs remain sensitive to operations. They pay close attention to operations, and they use resources so people can see and comprehend what is happening. They keep people informed. They're attentive to the front line where the real work gets done, and the authority moves towards expertise. They look at the role of the parents, the role of the physicians, the role of the nurses, and they make continuous adjustments that prevent errors from accumulating and enlarging. They take care of errors early. I once had an HR friend who said that when you see a problem, you take care of it early, because if you don't, when it comes to human relations, that it just grows and it gets out of control, and it can have a lot of ripple effects. So an HRO really keeps those adjustments in mind and attends to problems early on when they see them. HROs have a commitment to resilience. They anticipate trouble spots. They have a capability to improvise, and they develop capacity to do quick studies. They engage in a just-in-time learning. They also develop capabilities to detect, contain, and bounce back from those inevitable errors. HROs don't ever make errors. They try and make it as safe as they can, contain errors, and minimize errors. HROs may have trigger tools at QA meetings. In other words, that when they're running their QA data, they will see that, hey, my infiltrations have reached my threshold. I got to start looking at this, what's going on. Or maybe my infiltrations are below threshold, so I'll just continue to monitor this month. HROs also correct errors before they worsen and cause more harm. I talked a little bit about that. Another example would be the Toyota Corporation, where any employee working the line has the ability to stop the line if they see something that's wrong and fix it now before the entire car or truck gets built and then the problem's buried. HROs defer to expertise. They let decisions migrate to those with the expertise to make them. They try and avoid a rigid hierarchy or a deference to senior members. And just to talk a point about that is some of the friendly fire episodes that we've had in Afghanistan, and this comes from the Air Force and from military archives, have resulted in that whole problem with a deference to superiority. I can think of one particular friendly fire episode where the long and the short of it is that 2 U.S. jets shot down a Black Hawk helicopter. And the way it all happened is the fact that you had the Black Hawk helicopter traveling in a zone where they weren't supposed to be. They were under radio blackout, not using the correct channel. Up with the pilots in the Air Force jets, you had the senior ranking officer was actually the wingman, and the man in the lead was actually the junior officer. Well, typically in Air Force lingo, the lead pilot is the one who calls all the shots. Well, in this case, the lead pilot was deferring to his wingman, who was his superior, and his superior didn't have all the data and made a wrong decision, and so they shot down a friendly fire incident and shot down the Black Hawk helicopter. So you can see how it's very important when we look at this mindfulness to it. If you put all these 5 elements we just discussed together, you can get mindfulness, a Zen moment. And according to Wick, who are the gurus of HRO, I don't think that's Wick posing there, together these 5 processes produce a collective state of mindfulness. To be mindful is to have an enhanced ability to discover and correct errors that could escalate into a crisis. Is radiology and is your radiology an HRO? How do you get there? How do you stay there? And it's important to remember that HROs are a process. It's not a one-time change. It's a continual effort. You have to work at it every day. It's a step change. Cultural HRO step change is not triggered by magic. There's no magic bullet or fairy that will sprinkle dust on you make this happen. It's a culture change, and it's changed by small steps taken by leading members at all organizational levels. Leadership leads the way, and changing requires all people at all levels to lead by example and to participate. Now, why should you care about all this stuff? Why should we care about patient safety? Well, in 1999, the Institute of Medicine, the IOM people, published a report, To Err is Human. And in that particular report, they talked about adverse medical events. Adverse medical events, AE, is an injury, large or small, caused by the use, including non-use, of the drug, test, or medical treatment. It can be as harmless as a drug rash or as serious as death. This is just some interesting things that at the last lecture I put in. I know it seems a little bit out of sight, but it talks about equipment and about safety with equipment. These particular syringes have just hit the market, and what they do is they're able to clamp off at the end. They're chemo syringes so that you don't get drops of chemo. And this is a piece when you talk about HROs, organizations that are concerned with HROs look at new equipment. They look at things like this to help prevent important safety issues. Are we better off 5 years after the IOM report? What have we learned? Yeah. Reliability defined. We're not doing better after the IOM report. The IOM report really called attention to the fact that we have a problem in medicine. It's a great problem, and that we need to work on it. And when you look at reliability indexes, and that's how you define reliability, each one of these factors, when it goes up by 1, it increases tenfold out of the potential problems that can occur from it. And you can see how this all fits out. Here's all that data put out on this scale. And I guess one of the most telling things, and it comes out of the IOM report, that there was a problem in medicine and that we were a risky business. You can see that the medical risk is 10 to the minus 4. You can see that in actuality on this scale, commercial jet aviation, railways, and nuclear industry, and remember we started out with the Chernobyl pictures, are all safer at this point in time than medical risk. And this came out of a 2005 article, so it wasn't something that came out years ago that we're just now pulling up. Medicine does have problems. We do have areas that we can clean up, and it's just a risky business, and it's putting our patients at risk. With radiology improvement, I'm going to go ahead and turn it over to Dr. Dave Jordan.
So lest anybody think that we're not an innovative pair, we thought we'd have Greg present all of the sort of steely-eyed engineering science stuff from his nursing perspective, and now you'll have an engineer talking to you about personal interaction issues. So hopefully I don't come across as wildly dysfunctional here. So the backdrop of reliability science and of thinking about safety culture is really a tool set to think about how you can make improvements in your individual practice and how you can take small steps to try to get your department or your working group moving in a positive direction, moving towards that higher reliability index, towards that lower occurrence of failures, of adverse events, and better patient safety, as well as better patient safety for yourself and the folks who work around you. So I'll skip over the jokes about this in my desk for now. So in addition to the reliability science and the safety culture definitions that sound like something that comes out of an engineering textbook, there's really a presumption that in order to achieve all of these organizational goals of being mindful, of being sensitive to operations, and of letting decisions migrate to people with expertise, when you listen to some of these things and you think about it in the context of your own organization, and you think, okay, how often do people set aside their job titles on their org charts and say, who really knows how to solve this problem, right? And a lot of times there's an underlying question there. Is there a trust issue? Do I trust that person who's normally supposed to be my subordinate to make the decision, to make the call, to do the right thing? Is it my place to do that? So we're going to spend the next few minutes talking about the human side of this and the behaviors that go on between individuals, particularly in the healthcare setting, but really in any working environment. And what are the things that really undermine our ability to even try to accomplish those high reliability traits? So we're talking about things that cause people to make mistakes. We're talking about things that will cause us as healthcare providers to telegraph to our patients that something's not right. And they'll pick up on that, and they will leave the hospital or leave the clinic feeling like they had a terrible day because there was something off. There was a bad vibe. There was bad juju in the air, right? And all of this stuff will contribute, it's guaranteed to contribute to adverse events, higher costs of care, and good people leave, right? Everybody knows somebody that they loved working with who got fed up with something toxic in the environment, and they took off for greener pastures. So, what are some practical things you can do? You yourself, tomorrow morning, this weekend, whenever you next go into work, we're going to talk about this. So, this one we might not all be in a position to influence, right? But if your organization from the leadership has a patients first mantra, I would encourage you all individually to milk that for all it's worth, right? So pick up that shield and say, I'm taking care of the patient. I'm making the right decision for the patient. Right? And make your organization stick to that. If you're challenged about why you're doing what you're doing, say, well, hey, we have a patients first philosophy and I'm living that. So if I'm doing it wrong, please tell me. Another one is organizational clarity, right? So for folks who are in a leadership position, you really want to make sure that you're talking the walk, right? Is the colloquialism for this. So we all know of organizations that have some sort of a mission statement that was written to sound like it should be carved into the marble slab in the front of the building, and really doesn't have anything to do with how the employees inside that building behave day to day. Right? So it's really important to get this lined up. And it doesn't really matter how that mission statement sounds. What it matters is what does it say. And it should be very, very clear. So, in an academic medical center, you might hear that our mission is to heal, to teach, and to discover. Well, that sounds simple, but it really frames the organizational goals of saying, okay, we're here to take care of our patients. We're here to improve their health, to help them overcome diseases and injuries. We're here to teach other professionals, future generations, and we're here to do research and discover new ways of doing things. That's the framework, right? So, and the other piece of that is making sure that your incentives are lined up with that. Do people who follow the organization's mission, are they rewarded for that? Are they rewarded for encouraging others to do that? So think about that in terms of the behavior that you see around you. Is your organization walking the talk? And if you see disconnect, if you're in a position of leadership to be able to change that, great, go for it, take it head on. If you're not in a position where you feel safe challenging that, the fact that you don't feel safe is a separate issue that we're going to touch on, but one thing you can do is you can ask questions, right? And you can go to a coworker or a supervisor that you trust and you can say, hey, our mission is to do X, but I don't really understand how, this thing that happened earlier today or yesterday morning plays into that. Can you help me understand? And if they don't have a good answer, they may be inclined to go off and look. Human factors is a fancy name for making things as easy as they can be and as straightforward as they can be. This is something that is a big passion and a big interest of mine. So I have this sort of folksy way of telling people that, when it all comes down to designing processes, designing equipment, we really want to make things very, very simple and very, very straightforward, right? We want to make it harder to do the wrong thing than it is to do the right thing. And whether that means placing equipment in certain locations, whether it means things like color coding or locking things that aren't supposed to fit together, like the syringes Greg showed you, whether it means designing your staffing and your work shifts so that people can avoid excess fatigue, where they're more likely to make mistakes. All of this plays into human factors, right? How do we make this as easy as it can be? One thing to be careful about with human factors is there's a temptation to make things so easy that we can go on autopilot. So if we go back to the idea of mindfulness, okay, if we're trying to make things easier and more straightforward, it's not so that we can shut our brains off, right? It's so that we can free up our brains to pay attention to those more important signals. If I don't have to focus really, really intently to figure out which syringe goes on which connector because the blue goes with the blue, then I can pay attention to the patient. I can watch their facial expressions. I can watch how they move their body. I can tell if they are showing signs of pain that they may not have mentioned to me, right? So it's about freeing up your attention to notice those other signals. So again, culture, right? Culture is about how do we behave towards each other as employees, as providers and patients. You know, how important is it that we get along, right? And then this is something that will vary across organizations. Some organizations have a culture of what they call collegiality, but what it really means is that you're expected to not confront or challenge anybody at any cost. So that can be a real problem if you have a concern about the way somebody's doing something, but you don't feel like you're allowed to bring it up because you'll be seen as not collegial, as impolite to mention to somebody, hey, are you sure you want to do that way, right? And this may not be something that everybody can put into words, but I think everybody can sort of sense, okay, what is the culture in your organization? You know what it's okay to say and not to say, or to bring up or not to bring up with certain people, in certain meetings, in certain settings, and this goes beyond the basic rules about, you know, don't talk about a patient's chart in the elevator. Simulation is a great one. This goes straight to the military aviation. So in military aviation, which is at the far high end of high reliability operations, pilots go through a briefing and a simulated mission walkthrough before every flight. It doesn't matter if it's just a simple, hey, we're going to take this tanker and move it from base A to base B, straightforward, take off, fly in a straight line, land. They walk through it step by step, and they go through all the details. We're going to be on radio channel A. We're going to be talking to tower B. We're going to hand off to tower C. We're going to land the plane on runway 27 left, and we're going to taxi into hangar 5. They talk through it. They ask questions. They lock it all down in their brains. Then they go do it, and when they're done, they debrief. So they land that tanker. They get off the plane in hangar 5, and they go straight to the debriefing room, and they say, okay, here's what we did. Here's what worked, and here's what didn't, right? So the debriefing from one mission feeds right back into the next mission, right? And so this is where simulation comes in. You say, okay, if we're not really sure how to do this, or even if we think we're sure how to do this, right, we can walk through this. And the higher the risk, the more important this is. Let's walk through it. Let's make sure we know everybody's name that's going to be in the room with us. Where is Joe going to be standing? What is Sue going to be holding? You know, what's the timing? What has to happen? What are the important steps? The zero defect philosophy is a big one. Greg and I were just looking at some notes before we got on the line here, and there was a list of things which I won't restate here because I think it might be controversial. I don't think the world today is ready for it, but it's a list of things that I think we both sort of nodded our heads and said these are very common in radiology, things that happen, and we now have at least one speaker who is referring to these as never events, which I thought was very bold, but I think it's right. So you know, this is something that we can move towards and say, okay, when we see something that we've seen many times before and we know that it's not correct, it's up to us not to just shrug our shoulders and say, well, you know, that happens every few weeks, and you know, we talk about it and we say we're not going to do it again, and then 2, 3, 4 weeks later it happens again, but it's not that big a deal. Well, it could be a big deal, right? Think back to the Swiss cheese model, right? If you've got something that's not supposed to happen and it happens, you've just let a couple of holes line up. How many more slices of cheese do you have? In the real world, you don't always know. Stop the line is a big one. This is a hard one to implement, right? With Toyota, it's very easy because they did it by machine. It didn't take any supervisors or foremen or anybody else having to set aside their ego and say, yes, it's okay for anybody on the worker to stop, any worker to stop the assembly line. All they had to do was install a machine, so now everybody has a cord at their workstation, and when they pull that cord, the whole assembly line stops. It's mechanical, right? This is a lot harder to do in healthcare, but it's really, really important. Anybody who has any role in the patient care process that sees something that's amiss needs to be able to call that out to everybody else and say, before we go forward, we need to talk about whether this is okay. What did I just see? Did anybody else see that? Does it make sense? You know, and maybe the person that saw it is not the person that has to address it. But this really moves you a long way towards having everybody in the room acting as eyes and ears for everybody else. More opportunities to detect those small failures that can turn into an adverse event if they're not caught. When we talk about systems thinking, what we mean is we have to think about the ways that things interrelate, right? So a good example of this would be when you have one of these small failures. You say, well, you know, okay, that we see that all the time, and it happens. Somebody just wasn't being careful, and somebody checking, right? So that's a common simplified interpretation in a non-high reliability organization. In a high reliability organization, or in a systems thinking framework, you would say, okay, let's take an example of somebody who was supposed to get a chest x-ray and they got an abdomen x-ray by accident. And someone says, well, that was, you know, that's happened before, so they just didn't read the order carefully. And that's the human simplified explanation. The systems thinking approach would be to say, well, this isn't the first time this has happened. What is it about that order that's so hard to read? Maybe we need to change the formatting. Maybe we need to change the font, change the layout. Maybe we need to make it more obvious that this is a chest x-ray. Maybe we need to have that information fed from the computer where the order was generated into one of our radiology data systems so that the machine already knows it's supposed to set itself up for a chest x-ray. What other little pieces can we put in here to reduce the chance of that slip? And then standardization is a great one, right? How many times have you seen an airline let somebody on a plane that wasn't supposed to be there? Everybody's got a boarding pass. Everybody has to show their boarding pass. In order to get their boarding pass, they have to show the ID that says they are who they say they are, and then it gets checked 3 times, right? Checklists are great for this. I'm not going to stay on the subject of checklists for too long because it could be an entire lecture. But suffice it to say, checklists are a really good tool. The simpler they are, the better. And the higher the risk, the operation of the situation, the more critical they are. You don't want to make long checklists for stuff that's low risk. But pilots use these things all the time. They've got a big stack of them strapped to their leg, and they've got 3 to 5 really, really critical items on there. So again, they don't have to use their attention trying to remember which order do I have to do these operations if I have a fire in the engine. They just flip to the fire in the engine tab. They look down and they say, okay, I got to do these 5 things in this order. And in between, I've got to fly the plane. And then data, right? So I have to say, of all of the professions and disciplines that I've encountered as an engineer working in healthcare, I'm really, really impressed with all of you folks in nursing, because you guys really have embraced the idea of collecting and analyzing data and feeding that back into process improvement. So I commend all of you guys for that, and I would say this is the way of the future, right? We all hear about big data in the news. Data is driving everything, so we've got to collect it, we've got to analyze it, we've got to pull out the meaning from it, and we've got to act on it. That was a long slide. I lost my clicker here. Right? Communication is a big one. When you go through root cause analysis, you find people saying things like, you know what, people didn't communicate. People didn't hand off. So if you take away something from this, more important than anything else, it's to practice these communication skills, right? Take individual responsibility for what you see, take individual responsibility for your knowledge, and speak up, whether it's, you know, a colleague standing next to you, a physician you're working with, taking the opportunity to address a safety concern with a patient or a family member, really make that a priority. So, you know, again, we talk about that one pearl that you take away. Right? We're there, ultimately everything we do is for the patient. So keep that in mind and think about that as you weigh in a certain situation. Should I say this? Should I not say this? How should I say this? More communication is better. Now, with that said, there's some practical challenges to that. Some of you may be familiar with some of these safety communication tools. At our shop, we've got a little card that we carry around on our ID badge with the reminders for all these. So you have different structures, and these are shared tools where these can help you get around some of the interpersonal issues or some of the culture problems that exist. So if you have 2 people who say, okay, we're going to use this ARC method. Right? We're going to ask a question, we're going to make a request, we're going to voice a concern, and then if we're not heard, we're going to take it at the chain of command. These are ways to make this communication less personal or less threatening to another person. So this is part of what Greg mentioned before about the shared language. If you have these tools in your organization, you circulate these around. This can be done formally by leadership. This can be done informally by anybody working in the organization to just say to their working group, hey guys, can we agree among ourselves that we're going to use a tool like this? We're going to follow a process like this. We're going to put process into our communication. And this makes sure we don't leave out any important elements. And it makes sure that we're communicating information, facts, observations, as opposed to feeling like we're being personally threatened or challenged by somebody when they raise an issue. So here's a couple of more, right? So if you have a handoff between caregivers, then you can follow this SAFER script to make sure that you don't miss anything in that handoff. And then you have the SBAR-R model, where if you're trying to really quickly get something across to somebody and make sure that the message was received on the other end of the line. That's another big issue too, is that you can do your best to communicate effectively, but this is that handshake where now you get confirmation from the receiving party that the information that you've passed to them was understood correctly. So you got a couple of more here. You know, three-way repeat back, three-way read back. This is again that handshaking idea. This is what makes the internet work so well, by the way. So when the internet really started cooking, it's because when computers transmitted information from computer A to computer B responded back and said, yeah, I got that. And here's a little chunk of it, just to make sure that what I got was what you think you sent. And, you know, for the most part, things work pretty well on the internet with a very, very simplified scheme. The same thing can be true in your department for communication between people. So all you have to do is pick one of these that you like and get an agreement going with people that you work with frequently, whether it's people you hand off patients to or from, people that you're in the room with during a procedure, and just say, hey guys, can we try this? Can we all agree that we're gonna use one of these? And see how it goes. You'll probably see an improvement, and you'll probably feel yourself more confident in being able to raise issues where you may have felt in the past not as comfortable doing that. So, what kind of issues can get in the way of communication? Right? What can the communication issues have an impact on in turn? Right? So, I don't think anybody would question that if you have poor communication between members of a healthcare team, you're going to have problems with patient safety. People are not going to work as well together. You're really going to have a lot of trouble. And especially this gets bad if you have dysfunctional communication and dysfunctional relationships between the members of your care team in front of the patient or in front of their family. This can be disastrous. And we're entering an era where all of these data-driven efforts are going to be turned around under the lens of patient satisfaction. And we're not just going to be judged and paid anymore based on did we do the right thing or did it satisfy the objective of solving the patient's medical problem. We're also going to get paid based on how they feel about the experience. So we need to be more cognizant of this for a whole variety of reasons. Quality of care, patient satisfaction, our own business and financial health and well-being is tied up in this as well. So, if you see anything on this slide that describes anything you've ever seen or heard or experienced in your workplace, you're probably just like everybody else. This stuff is all over the place. Right? So what are we really talking about here? We're talking about lateral violence. We're talking about violent in a subtle way. Right? We're talking about hostile or passive-aggressive behavior between individuals as they communicate with each other. And there's all sorts of ways that we can communicate this stuff through body language, through tone of voice. You know, and over time, this stuff builds up. You know that there are people that you tend to avoid as much as you can. You don't talk to them. If you have to talk to them, you talk to them as quickly as you can. You get out of there. You try to avoid working with them. Maybe you go and check the schedule and try to see if you can get sent somewhere else so you don't have to deal with them, right? So, And not all criticism is bullying, but there's plenty of bullying to go around. So I don't think there's any question that this kind of behavior can have a serious impact on your ability to get to a place where people have a level of trust and a level of communication to function as a high reliability organization. So we lost some stuff from that last slide, but what it was a bunch of articles flying in talking about workplace bullying and intimidation, passive-aggressive communication between coworkers, just a whole host of things, advice columns, scientific peer-reviewed literature, everything in between, in healthcare, outside of healthcare. It seems to be a basic problem of the human condition today. And chances are not only are we as healthcare providers experiencing it with our coworkers, but our patients are probably experiencing it on a regular basis too. So if you want to make your hospital a safe and peaceful haven of healing, it would probably be best not to subject patients to an environment where this sort of thing is going on. With that said, I think the individual responsibility question is very important. It's very easy to say to yourself, hey, we're talking about culture, we're talking about organizational trends. How can I, as one person, have an impact? Basically, what's the point of me getting good if everybody else is still screwed up, right? What impact can I have? And the answer is that you may not be able to right the course of the whole ship just by being the one good sailor. But you can have an impact on the people that work with you immediately. You can have an impact on the patients that you take care of, and you have to start there. Because the truth is, none of this dysfunctional behavior feels good to be a part of. You know, I guarantee you that for everybody who's been bullied and felt bad about it, there's something that the bully himself or herself is feeling equally bad about, if not worse. So you can break that pattern, you can break that cycle, and you can become a little point of sanity in the midst of some of the chaos, and that will start to spread. Your mood will improve, your performance will improve, your rapport with patients will improve, your rapport with your team will improve, and people will start to see that, right? People don't want to walk around in a cloud of, you know, this is terrible, I hate this, I hate all these people, this is awful. People want to enjoy their work, so eventually they're going to start paying attention to what you're doing, and they're going to follow along and say, okay, I want a piece of what he's got or what she's got. And this really does work. I'm not just selling you something. So establishing protocols helps a lot. If you have an opportunity to lay out a standard operating procedure, this is great. Again, it's like the communication tools we talked about before. You get everybody on board and say, okay, this is the right way we're going to do this. We're all in agreement that we're going to do this. And then if anyone deviates from it, it becomes much easier to say to that person, hey, we have a protocol that says we're going to do X. It looks like we're about to do Y. Can you help me understand that? And then you don't have to make it personal. You don't have to say, hey, you're a jerk, you're doing this wrong. So this guy cracks me up every time I see him. We're human. We like things to stay the way they are. We like things to stay comfortable, familiar. We're wired this way from our very earliest days of, you know, hunting mastodons or whatever we used to do tens of thousands of years ago. You know, people call it the lizard brain. We're afraid of change even if we're miserable, right? If somebody said to you, hey, you could turn your world upside down and you'll be 1,000 times happier on the other side of it tomorrow than you are today, there's a lot of people that stay right where they are today. This fear of change is a powerful thing. So, you know, remember that. You can't run out tomorrow and change everything about the way you do business. There's a lot of different things we've talked about here as far as techniques, ideas, and it's a lot to bring to bear all at one time. And if you try something and it doesn't work, remember that this is what you're fighting an uphill battle against people's fear of change, human nature. Don't give up. You know, if you believe in what you're doing and you've got a clear shot at you know, making an improvement in your working environment or in patient safety, especially for patient safety, you know, you have to keep at it. You got to try something small, I like to say you don't want to trigger the immune response of the organization, and kind of work it in gently and slowly until people get used to that change and realize that this isn't so bad. We've got a better routine going here. So this is a really great quote from this paper called 5 System Barriers to Achieving Ultra-Safe Healthcare. And these are the guys, these guys here are involved in the Institute of Medicine report. The authors here will have some of these names are familiar, Dr. Berwick. And they said the most important difference among industries lies in their willingness to abandon historical and cultural precedent and beliefs that are linked to performance and autonomy in a constant drive toward a culture of safety. So what does that mean? What are we talking about there? And they're saying, well, what do we historically in our organization, what have we gotten used to doing in terms of trying to drive performance, right? Or in terms of people's autonomy or maybe lack of autonomy, right? Maybe we've developed a situation where we don't trust people to think for themselves. Or maybe we give people too much freedom and we don't expect them to standardize their work processes, right? Where's the happy medium? Probably nobody's at it. So what these guys are saying is the better able you are to overcome that fear of change, the more of an opportunity you'll have to make those positive changes once you've identified them. So I think that's pretty simple, even though they said it kind of roundabout way. So what can you do? You can do education. Education is always good. You can always tell people, hey, this is the right way to do it, and try to get them to buy in on their own. QI projects are great because data doesn't lie, right? You can do bad analysis, okay, granted, but for the most part, the data you can collect in a quality improvement project is strikingly straightforward. Most of these are not problems that are hidden in the noise, to use engineering parlance. When you start to collect data on something you suspect is a problem from your gut feeling, you're going to find some pretty compelling data. Zero tolerance policy for safety procedures, this is a hard one. I can tell you this from firsthand experience. It's not that easy to just say, you know what, we're going to have zero tolerance, because HR will come and say, there's no such thing as zero tolerance here, right? But the important thing is you've got established safety procedures. You've got everybody informed, educated, trained. They have regular competency updates. Everybody knows what they're supposed to be doing. You can't give anybody a pass, right? Even on that first simple write-up, you've got to say, listen, this is a safety issue, and I'm sorry, I like you a lot. You're a really nice guy, you're a really nice lady, but I have to put that write-up in your file, right? So take on the lizard brain, right? Don't let your fear of change get in your way. Let that be everybody else's problem, and then try to help them along. So this is absolutely going to have an impact on people's lives, right? We save lives every day in healthcare. Institute of Medicine has found that we don't always save them. Sometimes we're responsible for significant loss of life and significant loss of health in our patients. So we've got a lot of work to do to get better. So we all know now that adverse events do occur in hospitals. And you can target each one of those things, and you can say, okay, that thing that happened last week, we're gonna make sure that thing doesn't happen ever again. You can do that, but you'll be chasing your tail forever. There will always be another adverse event lurking behind some other hole in the Swiss cheese. So you have to think a little bit bigger and a little bit more strategically about, okay, what are the real root causes, not just what are the fake root causes. You have to move towards those high reliability attributes and say, okay, are we getting to the point where we're more sensitive to operations? Are we more preoccupied not just with what went bad last week and how are we going to fix it, but what could go wrong? Where are we leaving ourselves vulnerable to another problem? And remember, your safety culture may just save a life. It will improve your patient care quality. It will improve your patient outcomes. So with that, I believe, so we have some contact information here, I think. We had some details in here. And our references are in here, so we'll make sure to get these available to you guys. A lot of good articles and websites about some of the background behind some of the things we've talked about. And with that, we have a couple of polling questions to provoke you, or maybe just to poke you.
Yeah, Dr. Jordan, thank you for that overview of stuff. Before we get to the polling questions, I did want to just add a couple of comments for our audience. And I really started off with a 30,000-foot view, and Dr. Jordan brought it down to about a 10-foot view, but I still want to go a little deeper than that, because I think that really when we started off with this, we really wanted to give our audience something to walk away with. And so when we're talking about HROs and we're talking about some of the safety issues, I think it's important that we just go ahead and we say what those safety issues are. I mean, through my practice, and Dr. Jordan sits on our radiology QA committee, so I'm sure that he's seen some things at our hospital and even at some of the other institutions he's worked with throughout his career. We're really talking about wrong patients, wrong exams done on patients. We're talking about a wrong-sided intervention or a wrong site. We're talking about lost, mislabeled specimens. We're talking about reports in radiology lost in space. We're talking about patients that the incorrect clinical information came down on. And we're talking about patients who show up and their procedures canceled the day of service because of some of this wrong information. And these are really the events that we're talking about in radiology. And I would be amiss if I just told you all the theory and Dr. Jordan told you, you know, some of the pieces he did about what the IOM report said. If we really didn't get down to the nitty-gritty and give you a take-home, what can I do about this? I mean, we've hinted at it, but I think it needs to really be said right now. There are programs out there you can start. An example of one program that you could do in your very own department is a safety program that starts off with 4 principal safety practices. Practice with questioning attitude, communicate clearly, focus on the task, and support each other. And in those 4 tasks, you have to have buy-in from your whole workforce, from the residents, from the staff physicians, from the nurses, from the technologists. Another thing you can do when you roll out that program is a communication blitz. I've heard a lot in the literature lately about safety huddles. Recently, within my own department, we've just started a patient care huddle in the morning, and it has made a lot of difference in terms of now everybody's on board with what's going on. That communication is happening about that patient. It is talked about in the morning. Hey, we want to do this approach, so maybe we need this piece of equipment, or maybe somebody has another piece of information I'll share. Oh yeah, well that approach was tried 2 years ago and it didn't work, so maybe we need to try it like this. And if you do those 4 safety practices, if you invoke some of these huddles, some of the data I've seen back from other institutions that have enacted these things have talked about a 50% drop in their serious errors. So that's really some of the takeaway from this, and like I said, we feel very strongly about this. And probably my other comment that I wanted to make sure and mention, there was a video we did want to show, but unfortunately we didn't get the correct copyright clearances in time. But it is a Cleveland Clinic video, and it's, if you type in YouTube and do Cleveland Clinic empathy video, I think it brings something to the table. So many times when we're talking with each other, you know, we forget that everybody's human and everybody's got a cross that they're bearing for that day, be it the patient, be it your other colleagues. I would just ask that you take a look at that video. It just really gives you some food for thought as you're working on these processes of safety and what some of the human factors are that's being brought into this that you may be aware of or may not even be aware of for the day. So with that said, I think we're ready for the polling question. It says the Navy is an example of an HRO, true or false? Dr. Jordan?
So we have a few responses up there right now. Not sure how many total we've got on the line here.
I think we have pretty much everybody. Those who are moderators on the session can't vote, so I think we have a completed. We have a 93% true. Does everybody see that? 93% true and 7% false.
Yeah. So this one is true. So the U.S. Navy does have a significant structure in place to monitor for not only actual failures, but potential failures, and to fix those before they lead to problems, to contain those failures. And some of the areas in the Navy are much more HRO than others. So the nuclear submarine fleet, the aircraft carrier operations, these are sort of at the extreme far end of the hazard scale in terms of both the opportunity for problems and the size and scale of the problems. A fighter jet crashing on the deck of an aircraft carrier is a very serious problem. But even the more, we'll say, mundane naval operations require a lot of skill and a lot of precision to carry off. Even just something as simple as refueling or resupplying a ship at sea from a tender ship. So very, very complex, a lot of opportunities for deadly consequences from small errors. So absolutely. Should we have a next?
Let's post the next polling question. Yeah. What are the components of an HRO? Can everybody read that okay? All right, I think we'll go ahead and stop polling.
Well,
so go ahead, Dave.
I was going to say, so the correct answer is F, all of the above. So everybody picked one of the 5, so couldn't get this one wrong.
So everybody's a winner on that one.
That's good. Okay. Was there another polling question?
I'm not sure.
No?
No, there was not.
I think so. Yeah, Mike mentioned that there was probably only 2. Okay. So do you have closing remarks? Because there are people typing in some questions that I can mention. If you have any closing remarks.
Well, we would be happy to entertain any questions.
Yeah, I think we'd like to get over to see what the fine folks in our audience would like to discuss here.
So here's
All
question
right,
number 1. Mike, put it on the screen.
Can everybody see that, or should I read it off here?
Yeah, no, they can see it, but it's nice to repeat it for our recorded. So who determines whether an institution is HRO? Sorry.
Right. So there's a tongue-in-cheek answer, and then there's a real answer. So the tongue-in-cheek answer is Carl Weick at the University of Michigan Business School, because he wrote the book that defined this term HRO, high reliability organization, and set out what these principles are. But really the real answer is that it's more of an idea. So there's not a high reliability organization certification that you can go out and apply for, or have somebody come in and do an accreditation survey. It's really and like I said, there's degrees to it. So there are organizations that have thoroughly and completely embraced the high reliability organization behaviors and attributes, and then have reached a very, very high reliability index. So they may only have 1 error out of 1 million or 10 million possible opportunities for error. You have a sort of a continuum of organizations who are in the process of getting there. That's my best interpretation of it. I don't know, Greg, what do you?
And I would say that you're right on that, Dr. Jordan, that it is a concept as opposed to that there's a certification that you could get from it, or there's a regulatory body that comes in and says, oh, you've done this, this, and this, so you're a high reliability organization. It really is, as I stated earlier, it really is a culture. And it's a process, and it's a process of you getting there by using the components that we talked about. I think you can probably, in some respects, say, I am a high reliability organization or I'm not, depending upon the number of errors you have. You know, if you've seen those errors, you're doing these things to address it, and you start to get the error rate down, then I would say you're on your road to becoming a high reliability organization.
Mm-hmm. Yeah, I think that's true. Because really, actually, you know, those 5 characteristics don't make you high reliability by themselves, right? Having a lower error rate than you would expect is what makes you high reliability. Those 5 traits are found to be common to organizations that actually get there. And it also doesn't count if your operation, if whatever business you're engaged in is sort of trivially easy. That's never a problem for healthcare. We always have people's lives in our hands. Yeah, if there's really no such thing as a failure, then there isn't any such thing as high reliability in that business, if that makes any sense.
Yeah, it truly is. High reliability is a process, and by utilizing those 5 components, you become a high reliability organization through the process.
Yep.
That was a good question. Thank you.
That is a good question. The next one, Mike's going to post really quick here. It says, I have been a part of a root cause analysis. Oh, no, he's working on a different one. Sorry. Sorry, Michael. I have been a part of a root cause analysis and understand it is supposed to be unbiased and not pointing fingers. Is that real? Is that reality?
Well, that's interesting because I've been part of root cause analysis too, and I get what the person's trying to say about the unbiased and the not pointing fingers. And I guess it would depend upon the culture of your organization, where this happened. There's the theory that it's always supposed to be unbiased and not, but we're all human and we all bring in human emotions. And that's really why I would like everybody to take a look at that Cleveland Clinic YouTube video on empathy. It sort of speaks to some of this piece about the baggage people bring in and the baggage people are carrying around. And I think that's a piece of it. In theory, it is supposed to be unbiased. It's not supposed to be finger pointing when you have an RCA. It is meant to get to the root cause and to try and prevent this from happening again. I don't know what happened in your particular situation or who the players were. So maybe, it did feel like a little bit of finger pointing.
Yeah, it's interesting. I've sat in on a number of root cause analysis conversations where I've sat in the side chairs rather than sitting at the grown-ups table because I wanted to observe the discussion, the process, the dynamics in the room. I had not been formally invited to participate in the analysis. I was there in more of a consulting or an advisory capacity, so I didn't think it was a good idea to call out the fact that everybody around the table was sort of jumping to the conclusion that this was just somebody being lazy or dumb or asleep at the wheel or whatever these simplifications tend to be. When you jump to that and say, okay, well, we're going to point the finger at so-and-so, they just screwed up and they need to not screw up anymore. There's something else that happens too. Again, it's that simplifying interpretations thing. Well, what's the simplest thing? Well, you find the person, who was standing, at ground zero when the incident happened. You say, well, it's their fault, right? Because it's much more threatening to say to yourself, well, how might we as an organization have set that person up to fail in that situation? It's just a hard thing to do. And there's also, the other thing, if you want to go into sort of the philosophy of science and engineering here, there's a principle in science called Occam's razor that says, well, when you're faced with competing explanations for something, the simplest explanation is usually the correct one. And what I'll say about that is that's fine for basic science, right? That's fine if you're trying to tease apart how many different kinds of basic particle make up the universe. But a root cause analysis is not a basic scientific investigation of the nature of the universe. It's an engineering problem. And engineering is about teasing apart all that complexity to figure out how those moving parts work together, but it doesn't mean, throwing away the parts that make it messy. It's about, again, taking apart this complicated thing and laying out all these parts on the table on a nice clean white sheet and figuring out, okay, how do these things really behave with each other? And so I think people get a little bit misled in their haste to make things simple, easy to understand, easy to classify, easy to move on, and you really lose a lot of the value and a lot of the richness in that information of, okay, what are all the little warning signs we could tease out of this one incident that could help us prevent 10 different kinds of incidents from happening many, many times over each, as opposed to just saying, well, Joe showed up dumb to work today.
And in actuality, I'd like to add on the safety program that I outlined at the end of Dr. Jordan's presentation, we talked about the fourth point was support each other. And I think that is a very important point in all this, that we have to support each other. We have to embrace each other. And nobody comes to work saying, I want to make a mistake today and put my patient at risk. Nobody does. It's always a systems failure, and I think it's important that we all remember that piece. We got to look at what happened in the system to make this fail. Nobody wants to fail at their job. Nobody wants to put their patient at risk, and nobody sets out to do that. So it really is a systems failure, and people have to keep their eye on the system and how did the system set the individual up for this to happen, or the individuals.
Yeah.
Good question. Thank you.
I love that one.
Yeah, they've got good questions tonight. It's a little bit over, so I think that as long as if there's any additional questions, Greg and Dr. Jordan, are you okay with us forwarding those questions to you?
Sure.
Yeah, I'm all right with that. And I mean,
Okay.
I can hang around for a few more minutes. I mean, if people want to dismiss themselves, that's okay. I'm all right to hang around for a few more minutes too, if folks want to.
That's true. Well, let's entertain the last one that I see. It says you mentioned unsafe workplaces or facilities that aren't aligned with their mission. What would you do in these? What would you recommend to the staff in those situations?
So there's sort of
actually, just speaking from, I'm not sure who posted it, but just speaking from personal experience, as a chapter president myself for our local chapter, whenever we have our annual symposium, we're sort of addressed all the time. How do you handle that? How do you handle that? And we are doing Glaren is going to be doing a symposium, and part of it is lecturing on this exact question. So it's kind of interesting because facilities don't have the same. It's just interesting how do you tackle that, because we don't always have the best answer for that.
Yeah, I mean, an obvious or immediate safety issue. There's usually somebody who is a statutory or a regulatory steward of that. So I'll use radiation safety as an example. So in every facility that uses radiation, you have a radiation safety officer. And in theory, that person's role and their office and all of their existence is constructed in such a way that they don't have conflicts of interest in taking action to prevent a safety problem. So, in theory, a radiation safety officer is never supposed to get fired for shutting down an unsafe radiation use, even if it's, even if the hospital has to take a hit to their profit or their income. And so, depending on the type of issue, there's usually somebody you can go to who is the keeper of that type of safety, whether it's radiation or whether it's infection control or whether it's just sort of individual worker injury safety, those kinds of things. And in theory, those people should be easy to find, right? There should be posters up around that say, hey, if you have a concern about data security, or you have a concern about bloodborne pathogens or unsafe workplace, this is the person to call. So for an immediate sort of clear and present danger kind of situation, that would be the first place to go. As far as the other part of the question, the organization not aligning with its mission, mission statements are the province of the CEO, right? I mean, that's something that, when you're a CEO or you're a board of directors or somebody like that, you get to write the mission statement, and you're usually pretty insulated from what's happening on the front lines. That's why this high reliability stuff about sensitivity to operations and deference to expertise is so important. it's because of that insulation that tends to happen, right? In the military, the president certainly doesn't know how many pounds of steam pressure it takes to launch a fighter jet off the front of an aircraft carrier. So you probably want somebody in between those layers involved in the decision-making process about when to fly and when not to. But an organization at its best should have channels for that communication. So if people on the front lines are saying, hey, our day-to-day instructions or operations seem to be at odds with what this mission is, and we don't feel like we're fulfilling it, you would hope that there's some kind of a mechanism as people are going to their supervisors and saying, hey, I don't see the alignment here. I don't feel like we're accomplishing what this mission says we're supposed to be. How can we get more lined up with that? It's a really hard thing to do. You can be obnoxious like I am, and you can run around doing you can run around doing your various projects, and when somebody gets in your way, you can say, well, hey, this is a patient care priority. You can do that, and people will think you're obnoxious. But that's a really hard one, because again, you have traditionally in healthcare, you have these many layers of hierarchy, a lot of insulation between the people who write the mission statements and the people who carry them out. And every organization is a little bit different in how well information flows up and down those channels. I'd like to think an organization would be paying attention to those signals and saying, well, we either need to retweak our mission every now and then to make sure that it's true to what kind of our soul and our purpose as an organization is, and make sure people feel that they're hooked into how what they're doing is satisfying that mission.
And I guess the one point that I would like to add, and it's a difficult question to answer, as Dr. Jordan talked about, for the simple fact that all our organizations are different, and I don't know what the culture is in the speaker's organization that asked the question. But hospitals and organizations are taken very, very seriously, their mission statements and making their employees happier, because a happy employee translates down to a happy patient, and a happy patient votes well when you start looking at HCAP scores, and when you start looking at some of these other scores that the government's tracking for reimbursement. So what I would tell the person who asked the question is within your own hospital, make sure that when the opportunities come up, that you go to those meetings so that senior management can hear you, that when those questionnaires come out in your email, what do you think about this, what do you think about that, that you don't just dump it in the trash box and say it doesn't matter. I mean, I've known employees in past places I've worked that would do that because they said nobody ever pays attention to those surveys, so it's a waste of my time, so I'm not going to do it. Maybe at one time 20 years ago that was true. I think no longer true today. I think that they are taking all these surveys serious. I think they are searching for this feedback. They are trying to get things connected, because the truth of the matter is a happy employee is going to transmit that to the patient, and the patient will respond in kind. We're all in this together. I would encourage the person who asked the question to make sure you get involved in your hospital, get involved in those committees where there is feedback, and to let your thoughts be known on this. And you can present this information in a very nice way. It doesn't need to be a hostile way. Well, you're not following the, what you wrote up there, but just to say, hey, I think there's a little bit of disconnect. I'm just not feeling it, and I'm not getting it. Can you help me? Or maybe to give direct feedback that, the message isn't getting down to the people I work with. Is there a different way we can do that? Maybe emails, maybe paper. Maybe they need a town hall meeting with senior management. Some places have done that. I know in my own radiology department that once a quarter we do have a town hall meeting with senior management, and they'll answer any question that the employees have. And people have asked about the mission statement and how do we align with that and how do we do that.
And I think, Greg said something in there that was a clue to something I was thinking about. I don't want to leave you guys with the idea that, you should run around sort of being obnoxious with a cowboy attitude and sort of say, well, why aren't you, living the mission statement? I think the key phrase there is help me understand. And if you have an opportunity to talk to anybody who's in a supervisory or a management or even all the way up to the CEO in a town hall meeting, You can use some of these communication tools, and you can structure your question in a way that you can present it factually. You can say something like, my question, I'd like you to help me understand, our mission statement says that, we value patient safety as our top priority. And, in my day-to-day work, I've seen situations where, we have passed on the opportunity to purchase certain equipment that, all of us in my group feel strongly would improve patient safety. And so, we understand that budgets are a concern, or that the financial constraints are what they are. We also know, you have a perspective that we don't have. You have access to more information. You have people working with you who deal more directly with these issues. So please help us understand how, patient safety, how we're living up to our top priority of patient safety if we are declining to purchase vital safety equipment. Thank you for your time. Because one thing you may find is that there are other perspectives, or there's additional information that you don't have that will help you understand. And the other thing you'll find is that they may actually think that what they're doing is perfectly consistent, and it was only through trying to explain the answer that they realize, hey, something's off here. I think I learn more myself when I teach than anybody in the audience gets out of it. So I think that's also true when you have folks who are up the chain trying to put the pieces together for you. They may start to find some of the holes in their own thinking and their own perspective if they exist. So, use some of those tools and present it as a background of facts. Hey, this is what the mission statement says. This is what we observe. Help us connect the dots here.
Thank you, John, and we really very much appreciate you lecturing for us today and providing us with such a great lecture. Have a wonderful evening.